Thank you to all of our attendees today. I greatly appreciate it. And I also would like to thank our keynote speakers, very moved by the presentation that they presented. And I'd like to talk to us about how we can go about coming to some solutions for all individuals. So it's really my honor to be able to present to you today. As Denise had shared, REACH is a 501c3 global social impact organization. And we're really focused in on how can we improve the overall experiences of healthcare for both patients as well as providers of care. From our perspective, what we see is that there is a problem that exists within the industry in terms of its slow progression towards the adoption of digital health technologies. Even when we talk about the great adoption of telehealth during the pandemic, the reality is that for the majority of people, they didn't actually embrace it. Let's kind of look just for a moment at the statistics so you'll see what I mean by this. It's very common for an organization, and I'm sure you've heard of some, who have made the statement, we increased our utilization of telehealth by nearly 900%. But when you peel back the layers of that, the true reality of it is that that increase actually was an increase from a population perspective of merely 25%. So that means that 75% of the total population actually still didn't have an opportunity to leverage telehealth technology, even during the state that we're in with the pandemic. So that creates for a challenge. And so at REACH, we sort of ask ourselves, and we encourage others to ask themselves, well, why is this the case? What are the gaps that are sort of existing that are sort of persistent, allowing for the challenges that we have in industry to persist? And amongst them, there are essentially these sort of what we see as three core disconnects. That is sort of the perceptions, right, and the perspectives of healthcare administrators, the frontline experience of care providers, and then the expectations and the needs of patients. There's sort of these gaps between the three. And when those continue to perpetuate, then we continue to see challenges and the similar problems continuing over time. So we really spend our time focused in on looking at problems from a different perspective and then saying, how can we then drive deeper into evidence-based applications of technology by emphasizing research, education, and innovation technology, and showing others the how-tos. So I'm going to talk a little bit about how we're doing that within REACH and as it relates to some of our national programs. One way that I like to talk about this challenge is really through the lens of how incredible we are as a nation, right? We're number one in a lot of things. And I think we noted during the pandemic that we were kind of number one amongst countries with the highest rates of death per capita. Those are the kind of statistics where you don't want to be. Those are the rankings where you don't want to be number one, right? But where we are number one, where it's desirable, it's an indication that we have the ability to be able to be really ranking very well in a lot of other areas. If you take into account our GDP of over $20 trillion, if you take into account our international influence and our ranking in terms of having not only the number one ranking in terms of the most number of Nobel prizes in medicine, but the reality that not only are we number one, but we are 3 times higher to the second ranking top Nobel Prize award winning countries. That says a lot, right? Same is true when it comes to our global innovation. We may not be number one this year, but we have been in the past. We look forward to being number one in the very near future. But that notion that we are ranking amongst the highest of all nations when it comes to innovation, that really says something. But the question becomes, how are we applying it in ways that directly impact the lives of all the individuals within the US in a manner that improves their overall health and well-being? For example, we know that unfortunately, we're also number one in another area that's not so desirable. We have the highest rate of maternal mortality amongst all developed countries. And our rates of death are unfortunately increasing. And it's not only the rate of death, the rates of morbidity as well are also being challenged. In fact, almost every year, over 70,000 women have some form of injury as a result of complications of pregnancy. So the question becomes, what are some things that we can do to address these issues, and how can we take advantage of all of our research, our innovation, and our technology to be able to address these problems and do so in ways that are cost effective? I mean, think about it. The cost of a person, a woman who has preeclampsia is 3 times the cost of a normal pregnancy. So the opportunity here is significant, both in the lives of the individual, the lives of their family, the community, but as well in terms of our economic stability. So what's contributing to these challenges? Well, you know, what I like to be able to share, and I'm relieved to be able to share it, is that over 75% of maternal mortality is preventable. And the reason it's preventable is because there's some key factors, preventable factors, that are contributing to the challenges that we have. And these are predominantly delays in individuals seeking care, delays in transportation, delays in diagnosis, and dare I say also misdiagnoses, as well as delays in providing appropriate treatment. And so when you think about those 4 areas of delays that are contributing to maternal death and injury, you can then begin to see how doing something such as applying digital technology really has the opportunity to open a window to gaining insights early enough and taking on preventative measures that preempt so that we can prevent. These ladies that you see on the screen here all have a story. I'm not going to go through everyone's story today, but what I will do is just take a moment and ask you to go with me on this journey, essentially, of recognizing some of the things that they have in common. So superficial to begin with what is the obvious in terms of what we see on the screen. What you don't see on the screen are the things around the signs, the indicators that were occurring when these women started to have complications. What you don't see in the pictures, if you will, on the screen, you see it in my text to the left, but not in the photos of the ladies, is that all of them had spoken out that they were experiencing some form of complication and no one was listening. Remember, being a difference between hearing, right? We hear things, but doesn't mean that we're necessarily listening, and to take that second step and begin to respond. When we start to talk about technology, these abilities to not only to hear, but to listen, and in some instances even be forced to respond, all become very possible. Preventative protocols is another challenge. A failure to prevent, in some cases, to prevent standard protocols was an issue. The continuity of care. Many times, high-risk women will go in and they may show up, and when they may present with high blood pressure. And it's sort of like considered sort of an anomaly, right? Because you can't just base hypertension or high blood pressure based on one incident or one encounter. So you encourage the patient to continue to monitor. But one of the challenges that happens, and is a reality across all of healthcare, is that the majority of our time, right, certainly significantly less than 5% of our life is spent in the clinical setting. So all of the drama, all of the real complications, generally speaking, that occur begin to occur outside of the clinical setting, outside of the 4 walls. And there's this lack of visibility to what's going on. So in the instance of many of these women on the screen, issues like swollen hands and swollen feet began to present, and the information wasn't being shared, or they may have taken their blood pressure a couple of times, maybe once or twice during a week, but the notion of having that continuous monitoring, particularly when they were at high risk, didn't occur. Some other harsh realities of what's transpiring is that we have a shortage of healthcare providers, healthcare professionals. It's a reality, and it's going to continue in the future. And so when we look to the area of maternal health, maternal deserts are a real reality, not just in rural areas, but also in urban areas. There's a shortage of specialists, and there are obstetric deserts, areas of the US in which there are no obstetricians, no specialists available. So there really is this need to begin to leverage technology, but also to use technology to build up the skill sets of lower skilled clinicians, and to start to put together more multidisciplinary teams that take into account the benefits of additional resources, such as doulas and health educators in the communities, to really help broaden our ability to have a more profound effect, positive effect, locally within communities, with individuals that members of the communities and women in the communities are familiar with and trust. So technology really has this opportunity for us to connect, communicate, and to collaborate. And so for our organization, for REACH, we started listening intently to what we were hearing women say, and what some of the organizations that are out there, such as the March of Dimes, were contributing, and ACOG and others. And things that we kept commonly hear coming up were things like the signs and symptoms, such as blood pressure, as an example. In fact, over 35% of complications during pregnancy that have resulted in death have some form of hypertension or high blood pressure associated with them. We also noted that oftentimes these things come on suddenly and tend to present themselves during third trimester. So we started to say, what if we begin monitoring women during their third trimester, monitor their blood pressure? Like, there's no increased risk in monitoring blood pressure. Of course, it requires us to, number one, ensure that women have access to blood pressure monitors, ensure that they know how to properly take their blood pressure, ensure that they're educated about how to interpret the data, and ensure that their clinicians have the visibility and have a confidence in reliability and the validity of the data that's being shared. Those things are all true. But in and of itself, asking women to begin to monitor their blood pressure began to seem like a no-brainer. And this is where we said, let's start this campaign. And we did. We started a campaign last year. That campaign is known as the National Save Moms campaign. And we're emphasizing the need for really moving towards a reduction, significantly meaningful reduction in maternal mortality and morbidity. And to get there, that by not only monitoring blood pressure, but other known signs and symptoms, and communicating that information and promoting the collaboration between the multidisciplinary care team and the patient, that we can go a long way in terms of the reduction of maternal mortality. This resonated with a lot of folks. It resonated with those in industry, such as HIMSS, who I am very grateful for being our partner on this program today, and others whose names are familiar to you, like the American Medical Association, the American Heart Association. But we said, those in industry, we talk the talk, we drink the Kool-Aid, right? We need to really go a further step. How can we get technology manufacturers to participate, not just in the form of someone creating a new app, right? There's like over 1 million healthcare apps out there. It's not just about creating an app. It's about making affordable access to blood pressure monitors, glucometers, pulse oximeters, so that the everyday individual can afford them. So when we make these recommendations, that they are able to have access. I mean, let's face it, the majority of individuals under the age of 65 do not have blood pressure monitors in their medicine cabinets unless they have been unfortunately identified as having hypertension or pre-hypertensive, right? And while of course that number is growing, the vast majority of women who are in childbearing age, that is, through the age of approximately 45 years of age, generally speaking, don't have those types of devices in their home. So we need to figure out a way to communicate the importance and reduce the cost. But that's not enough. We need for both federal and state to participate. Yesterday, we spoke with some members of Congress, as well as other stakeholders within the technology space and providers about applying these technologies. And today, we're speaking with you about the need to apply these technologies. We're looking for, on a state level, your participation in helping to improve the health of women by making it easier for them to have access to information. REACH already knows from the research that we've done that women are ready. And in fact, I am honored to be able to share with you some behind the scenes sneak peek of some preliminary data that has not been shared anywhere else thus yet. This is data that we began collecting in 2020. It is our Women's Views on Maternal Care survey, in which we have had over 800 women today, thus far, pregnant women, to respond. There are lots of amazing insights and data points, and I just thought I would share just a few, just a snippet of what they're saying with you today. First off, you all might be nodding, yep, Fran, I've heard all of this before around, hypertension and pregnancy and gestational hypertension and preeclampsia, et cetera. This is something that we're riddled, this challenge that we're riddled with. But interesting enough, the majority of the women that we spoke to, they weren't at all familiar with high blood pressure during pregnancy. And nearly 50% of them believe that there's insufficient information on the topic. Like they didn't actually know where to go to get the information, or what resources could be considered reliable resources, especially knowing that many of them are seeking information outside of their encounters or their visits with their obstetricians and gynecologists. The other thing that we found interesting in the data was related to clinical empathy, as well as related to clinical-based information-based decisions. Many women felt that there just wasn't enough information being collected and that they weren't being listened to. In fact, over 40% felt that the clinical information being collected was not enough, and that they felt like it would be a worthy cause for their clinicians to start taking up tools like remote patient monitoring tools, leveraging telehealth, et cetera. Remember those statistics I gave you earlier about really the broader population, only about 29% of the population adopting this telehealth technology. Well, those numbers are even smaller when we look at pregnant women. Fewer than 10% had actually used digital technology, but I would say almost all, about over 90%, were eager to learn more about whether their providers had it available, said that they were willing and interested to use it. And they also said that they'd be very keen on monitoring their blood pressure if their provider told them that they needed to do so. So we have a ready population who themselves, obviously, they are well vested in ensuring that their safety, right, and the safety of the outcome of their pregnancy. So this is what prompted us to start the National Maternal Mortality Prevention Remote Patient Monitoring Demonstration Project. This is intended to be the largest national demonstration of the application of remote patient monitoring for maternal health purposes in the United States. And we felt that there would be no better place to begin this effort than begin with those states that have the highest rates of maternal mortality. Now, it's not to say that those who aren't in the top 10 can't participate. We want everybody participating. But we want to put a special shout out, a special call to action for those states that are most challenged. It's not my job today to call your state out by name, but if you don't know how you rank, you can always reach out to me and I can let you know. But we do encourage everyone, every state who's participating today to participate in this program. And it's a pretty simple ask. We're looking for clinics to come on board, particularly those rural health and community health centers to participate, those of whom, of course, are offering maternal health programs. And essentially, you would be provided with a simple remote patient monitoring platform with a companion care plan provided through the American Heart Association, and that we would monitor an identified group of women from your communities for a 6-month period, optimally beginning in 3rd trimester. Can they start earlier if you know they're at high risk? Yes, and we can talk to that. Can they participate and continue on a little bit longer if they need to be monitored beyond the 3 months postpartum? Yes, we can talk more to that. But our goal is really to get as many women engaged as possible, and at minimally see 1,000 women, both expected and new mothers, to participate monthly over the course of the year, beginning, in fact, now. For us, it's all about education and early prevention. Connect, communicate, and collaborate. Simple tools that can be used with your practice to help you get started and that allow you to have the visibility that you need from a clinical standpoint, so that you're able to have access to early information, of course, leading to early intervention, which equals early prevention. And what we love about the simplicity of the tool is it can be used either standalone, depending upon the maturity of the IT within your organization, but it is also a fully interoperable system, as we pride ourselves in following some of the golden standards that HIMSS and many others have put forth in terms of ensuring that there's an easy flow and share of information between providers and within institutions and technology solution providers. So what are the 3 steps, 3 simple steps to participate in the Maternal Mortality Prevention RPN Demonstration Project? I think that Daniel Montez will be putting this link into the chat window. It is savemoms.us. It's where you can go to get more information and basically submit an interest form, right? Tell us that you're interested, sign up for a demo and complete the enrollment form, and then we'll get started with onboarding your staff, training staff and patients. We believe in the train-the-trainer model, and we'll be right there with you, kind of providing that white glove touch to ensure that you're successful in your implementation at your facilities. Our goal is to have a minimum of 100 women to participate per site. So that's something to note. And I think that given the rate and the state of women's health, maternal health, those are very easy numbers. I'm sure many of you can already begin to identify the population, high-risk population, who would be most notably and served. And then thirdly begins the evaluation and reporting. The nice thing about the evaluation and the reporting is it's all digitized, right? It's all digital. So the data will be easily and readily available to you, as well as it will be to the researchers who are doing the analysis work. And we look forward to your participation. Let's plan on being #1 for best maternal health outcomes. I think that's an awesome goal for us all to be on board with. And enrolling in the Maternal Mortality Prevention Remote Patient Monitoring Demonstration Project, which emphasizes research, science, and high quality care, is one way that we can all get there together. I want to thank you so much for your time. And I'm now going to pass it over to Denise to take us on for the panel discussion. Thank you, everyone.
Fran, thank you so much for sharing those shocking statistics and offering solutions, including an overview of the Maternal Mortality Prevention RPM Demonstration Project. I believe we have time for maybe one question from the staff while we transition to our panel.
We do have a question. How have digital inequality and gaps in telehealth contributed to the disparities, especially in the face of COVID-19?
Well, certainly gaps in digital technology are a huge problem, as is digital literacy. I want to break that into two parts. #1, digital literacy, meaning providers, are interacting with technology every day, but our data shows us that even during the pandemic, over 50% of clinicians had to fend for themselves. Their institutions did not provide them what they believed was the necessary training for them to even be able to leverage digital technology during the pandemic. And that's a problem. The other is that from the digital divide perspective, in terms of individuals, right, within the community themselves, there is a gap there as well. I will say that, however, that over 75% of individuals in the United States have access to a smartphone device. And you have to remember that a smartphone is one form of cellular communication. The smartphone is the thing that looks like it's like a computer in your pocket, right? But we do have lower form technologies, some like to call it the flip phone, but it's a cellular phone that people do texting on. And we have seen, even on a global scale, the power of what can be done when we're just using the most basic form of SMS texting to make a difference. I'll give you a great example of this. An excellent example of this is in HIV/AIDS. And the reason why I choose this is because, well, obviously it's transmitted differently in terms of a condition which had broad-reaching global impact, right? Very devastating for many people. Our ability to be able to educate individuals in some of the most remote places of the world came down to 2G, not 3G, not 4G, not 5G like we're bragging about today, but 2G technology, enabling us to get information to people in the most remote places, or places where they're barren with limited resources. So in some respects, I would say that one of the things around the technology and infrastructure is not just the absence of it, but our failure sometimes to remember that even the most basic technology is at our disposal to help individuals. The other thing I would say that, and acknowledge, because I'm sure there's some folks saying, well, Fran, we have difficulty getting access to, internet within our communities. And that's exactly right. So what do we do in those situations? Well, I've had the good fortune to have worked with some longstanding obstetricians and gynecologists who also have had this sort of affinity towards digital technology, who've gone into some of the most, most resource-constrained regions of the world, places where you could only get to on foot. And we leverage a hybrid technology, a hybrid application of technology. What do I mean by that? Well, remember earlier I talked about multidisciplinary teams, and I referenced the use of doulas, and I even said community health workers and community educators. Think about the programs where we've been the most successful, like in diabetes prevention and in hypertension management. The programs that have been the most successful have been hybrid programs in which we educated hairdressers, where we educated housewives in the community, where we went into churches and we were leveraging the word of mouth. I think the biggest tool we have that we sometimes underappreciate is our voice and the individuals in our community. So hybrid models is the way to address that. And also with the technology, we've learned ways to go about introducing it so that we can have both what we call asynchronous and synchronous time, so that we're still able to collect data even when we're offline and be able to pull resources in. Lastly, I'll say that companies such as AT&T and many of the other telco providers have now introduced programs such as the First Net program that is bringing access to broadband services, even to the most remote places, inclusive of such as the Appalachian Mountains, and that's made for a really big difference. I know that was a long response, but I wanted to be as comprehensive as possible because everything you say is going to lead to but. So thank you for the question.